This is a patient with an in and out syndrome. She has a symphony toric that is on the wrong axis by 90 degrees. So it's doubling her astigmatism. She has like 6 or 7 diopters of astigmatism. The superior haptic you see here is in the bag, and I'm trying to dissect this open. But the inferior haptic is in the sulcus, and the capsular bag is collapsed behind the implant. And as I inject viscoelastic here to try to dissect the bag open, I can see viscoelastic escaping into the vitreous cavity, and that tells me that there's a posterior capsule defect. So I pull this haptic out of the capsular bag and bring it up into the sulcus. I'm aware that there's a posterior capsule defect. I'm now going to bring the other half of the lens out of the sulcus and bring that up into the anterior chamber. And now I can go ahead and cut this lens in half into two pieces and remove it. So here we're cutting the lens in half and taking it out. So the plan here is to try to replace this with a proper power Symfony toric lens on the correct axis in the capsular bag, but we have some challenges ahead of us. So we're going to go ahead and take this lens out so we have a clear working space. I would have kept this lens if it was the correct power, but it was not. So now we have the lens out of the eye. We're going to try to reopen the capsular bag. This is my trusty LASIK cannula, and I'm trying to slip into the space between the anterior and posterior capsule, but it's too well fibrosed here, so I'm just not going to be able to get in there, especially since the posterior capsule is pretty floppy because she does have a posterior capsule defect, as you can see at around 7 o'clock here, 8 to 7 o'clock in this video. We're trying to dissect this open. I decided to go past where they're fused, where there's an opening, and use a wave of viscodissection to try to reopen the capsular bag without causing the posterior capsule to flay open. Here you can see the posterior capsule fibrosis coming off the posterior capsule. I've now reopened most of the capsular bag, but there's an adhesion between the iris and the anterior capsule. So I'm going to go ahead and cut that with a micro scissor. Here you can see me cutting those adhesions very carefully. And I'll now use the micro scissor to try to reopen, separate the anterior from the posterior capsule here and create a space so I can potentially put the new lens in the capsular bag. So here I'm adding some viscoelastic, and the capsular bag does open, and I'm aware that there's this defect here, and I'm going to just use the micro scissor here to make sure that all of the adhesions are laced between the anterior and posterior capsule, and I have a good working space. As I do this, I can see that there's some vitreous presenting, so I'm going to go ahead and clean that up. I place a couple of pars plane trocars here and go ahead and do a vitrectomy to make sure that there's no vitreous in my working space. Once this is completed, I can go ahead and start thinking about reopening the capsular bag as much as possible, viscoelastic for in the bag placement of a new lens. So here I'm lysing any adhesions that might still be present between the anterior and posterior capsule with my micro scissor. I think I've created a completely open working space here. There is a defect in the posterior capsule, so I'm aware of that, but I think it's going to be out of my way. I'm going to place my iris retractors on the anterior capsule to retract that so it'll be easier to put the new lens in the bag. I'm going to inject the new lens so it unfolds just under the anterior capsule, and then tuck the unfolding haptic, as you see here, into the capsular bag under the anterior capsule here very gently because there is a posterior capsule defect and I don't want that to spread. I'm now going to rotate the lens so it's on the correct axis, which in this case is around 23 degrees. The lens is very stable because there is posterior capsule in this region. Capsular defect is out of the way. I'm now going to go in with my pars plana 23 gauge vitrector and finish cleaning things up. And also I'm going to expand the capsula opening a bit so that she won't be bothered by glare as much. I want to be conservative here. I can always add more YAG laser later on when things fibrose in place a bit. But the lens looks very stable. It's on the correct axis. I'm very happy with that. I now use anterior chamber infusion and the vitrector with the cutter off to remove the viscoelastic from the anterior chamber. I put a suture in the main incision to make sure that's watertight. I adjust the pressure to physiologic, and the case is completed. The lens looks well centered on the correct axis. Thank you for your attention to this case.